Morning, good afternoon, good evening, wherever you are, and welcome to this UNICEF and TechNet webinar session. Today we'll discuss the launch of operational guidance on zero-dose strategies to improve routine immunization and other child outcomes. In this session, we'll explore the recently launched, in this session, you will be able to listen to the panelists in English, French, Spanish, and Arabic. To do so, please click the globe icon and select the language in which you'd like to listen to this session. The globe icon is at the bottom of your Zoom window, and you can select all the different languages from there. We'd be happy to know who's with us today, so please introduce yourselves in the chat box and tell us your name, where you're from. You can also use the chat box if you need any technical support, and I'll be here and do my best to help you with any issue you might encounter. If you have any questions during this presentation, please use the Q&A box. So please avoid using the chat box for questions, just to make sure that everything is centralized in the Q&A box. It makes our panelists' life easier to select those questions that will be answered after the presentation. Finally, the session is recorded as usual, and we'll share with you the links to the recordings in all languages, as well as the slides by email once everything is online. I hope you'll enjoy this session, and I'll give the floor to Ibrahim. Ibrahim, the floor is yours.
Thank you, Alex, and good morning, good afternoon, good evening, colleagues. Welcome to this launch of the operational guidance, which is a multi-sectoral zero-dose strategies to improve routine immunization and other child health outcomes. Myself, Desri, and other panelists from Philippines, Libya, and some of our country and regional offices are going to take you through this through engaging sessions, including panel discussions, some recorded videos, as well as question and answers. Next slide, please, Desri. So this slide, so basically Alex has taken us through the welcome and housekeeping. The next session is going to be a presentation, which is basically introduction of the guidance. So this is going to take us 20 minutes. Myself and Desri are going to give you an overview of the guidance document, and you could have access to the guidance document by using your phone to snap the QR code, and you go directly into the guidance document itself. Following the introduction, we move to the first panel discussion with the Philippines country. Basically, there's a case study the country has worked on. We're gonna see a recorded video of that, and then two panelists are gonna have some discussions around that. That is gonna take us 25 minutes, and then lastly, we're gonna have an interesting panel discussion with the first country that we've rolled out this multi-sectoral guidance, and they've initiated the development of their national plan on this, which is the Libya country office led by the national EPR manager, Dr. Salem, and his team. So we're going to have that, and then we open up for Q&A. Please feel free to send any chat questions in the Q&A box. And also, as I've seen, you already introducing your name. And also, please tune to the frequency for the respective language translations that suit you. Next slide, please. So this is fantastic. So that just shows the cover of the guidance, operational guidance, if you'll have seen it. For those who have seen it, and for those who haven't, this is how it looks like, the cover page. Next slide, please. So basically, what are the objectives and scope of this? First, the key objectives of the operational guidance is meant to assist stakeholders in working collaboratively to address the issues of zero-dose and under-vaccinated children. As you know, globally, we have around 14-15 million zero-dose children, which has increased particularly during the pandemic. And then also we've had more than 20 million under-vaccinated, so that is significant. We're looking at opportunities to see how we can reduce the numbers of zero dose in line with the immunization agenda 2030, which has an ambitious target of 50% reduction by 2030. So this is meant to help us in a more coordinated fashion achieve that, but also, secondly, to provide an approach for integrating high-impact interventions. As evidence has consistently shown, zero-dose children represent multiple deprivations. So it's a proxy for measuring multiple deprivation, and we've seen significant overlap in terms of zero-dose children and other deprivations like lack of access to water, sanitation, and hygiene, limited or lack of nutrition access, bed registration, and other things. So we feel this operational guidance provide a more comprehensive approach to help stakeholders to plan these interventions in a better and coordinated, deliberate way to have transformative. So what are the scope? First is one, strengthen cross-sectoral collaboration. We want to see how we leverage the different sectors, their comparative strength, and also through that collaboration, address the potential gaps or weaknesses of individual cross sectors. Secondly, is having a transformational shift. A lot of the integrated interventions we have mostly been opportunistic, but this provides a framework to have more targeted, deliberate, and coordinated action, which leads to a more transformational result. And then thirdly, basically, this is meant to strengthen existing systems, not to create any any new vertical interventions or programs or coordination mechanisms, but rather to harness the different component coordination mechanisms and delivery service delivery points to have synergistic outcomes, if I can say it that way. Next slide, please. So basically, you look at the current policy landscape. Currently, we have the Immunization Agenda 2030, which is basically the overarching document that guides the immunization agenda in this decade. And we're basically half point into the IA 2030. Basically, we've been discussing doing a midterm review to look at the last 5 years and see how we can plan for the next 5 years. As I mentioned earlier, the target is to reduce zero-dose children by 50% by 2030. And then we also have different individual or institutional documents from different stakeholders, WHO, UNICEF, Gavi. But just to highlight UNICEF, for instance, we have an immunization roadmap that also aligns with the timeline of the Immunization Agenda 2030. And all these are within the overall envelope of the SDGs, basically. And these global strategies, including the primary healthcare framework, the Gavi strategy, as you know, currently we're working on the Gavi strategy 6.0, which is going to look at the interventions between 2026 and 2030. So all this are looking at the policy landscape that will help us to better program. And not forgetting the different respective sectoral policy strategy documents that are out there. Next slide, please. So what was the methodology that we used for this? The methodology was pretty robust, basically consultative, a lot of iterations, a lot of debates, a lot of discussions, and also achieving some form of compromise. But basically, first and foremost, was looking at the existing records, reviews, basically doing a desk review of available data, including peer-reviewed publications, program reports, and policy briefs, and also harnessing some of the pilot interventions in terms of looking at how multisectoral interventions around zero dose happen across some select countries that we've initiated. Then secondly, we had a lot of consultations across different stakeholders, looking leveraging the different platforms, the different link serves, UNICEF staff, different partners, WHO, CDC, Gavi, other partners, including non-governmental organizations, but also leveraging the different working groups that are there and the different focal points across agencies, as you will likely see in the acknowledgement section of the document. We also conducted a survey, basically trying to, based on the findings from secondary analysis, desk review, to understand what exactly do stakeholders need, or our colleagues, what do they need to be able to program better in a multisectoral environment. And that particularly helped in shaping the document and prioritizing, focusing on the key levels of change as described by our stakeholders and partners, as well as also looking at different data that's available out there. Next slide, please. So who are the target audience? Basically, we're looking at, this is not just only, of course, primary target audience being immunization stakeholders at the global, regional, and country level, as well as subnational level, but also non-immunization stakeholders, particularly in sectors or interventions that has a bearing with the zero-dose child. And this can vary from country to country. For instance, in some countries, you're going to see pairing or bringing together wash and nutrition makes more sense. In some, it's going to be education, social policy, bringing that together, or pet registration. So these different stakeholders within the country itself are considered critical stakeholders and our target audience for this document. But of course, not forgetting the leadership of the government, the ministries of health, ministries of planning, ministries of finance, ministries of education, and other line ministries, as well as subnational entities, non-governmental organizations, and civil society groups. Next slide, please. So what are the guiding principles for this document? First, as I said, based on all the secondary analysis and the survey, we understood that one, leadership is key. We need buy-in leadership from the government, as well as building leadership capacity. Particularly, strong coordination is important because we realize that to be able to drive the agenda, leadership is key in a more coordinated way. Secondly, is collaboration. This is trying to bring together and addressing the internal and external barriers across sectors, because we know often sectors are programming in silos, and we want to bring them together to be able to harness the comparative advantages of the different individual sectors. So that is crucial, and it's one of the key principles that this document adopted. Equity, very important. This is basically, as you know, the zero-dose agenda drives drives equity. So we're trying to prioritize the most vulnerable population, and these are usually, as I mentioned, affected by multiple deprivations. So rather than looking at in the programming in silos, we rather look at the child or the individual as a whole to address the most critical needs, which the person is deprived. People-centeredness is one of it as well. It's centered around people. Participation is key. We have components within the operational guidance that ensure community and stakeholder engagement at every level and every stage of the document. And then, of course, not forgetting the system strengthening. This is key. It's basically meant to strengthen, build resilience of the system, and to make sure that we don't duplicate, but rather consolidate on the different pillars of this. So I hand over to Desiree to take us to the second part of this, actually going into the details of the guidance. Desiree, over to you. Thank you.
Thank you, Ibrahim. So we would like to highlight to you all some of the features of the guidance, and just to emphasize the way that it was developed. The diagram here gives a conceptual representation of the approach that the guidance takes, following a typical program cycle, which follows phases of pre-planning, design, implementation, and monitoring. So what was key to ensure with developing the guidance was that it would be applicable to any existing program cycle and systems, and rather than creating a standalone model. It focuses on evidence-based mechanisms and processes. We really promote and encourage through the guidance the development and contributions that are needed to the evidence base going forward, but the guidance is underpinned by the current evidence. And it's concentrated on enabling collaboration with particular emphasis on early stages of coordination, planning, and design. So in the phase 1 and phase 2 that you see here are really where the large body of the guidance is sort of a little richer and deeper to really enable successful collaboration through those initial steps of foundational work. And then it reinforces adaptive design and redesign and adaptive monitoring to learn from processes, learn as sectors engage, especially in new initiatives, and to make adaptations as needed. Contextualization is also strongly reflected with a lot of practical application for various settings. This just outlines a little differently the 4 phases, and so represents sort of the steps that would be taken within each phase toward transformational multi-sectoral programming. And as Ibrahim has already mentioned, we really the tools and the guidance really promote sort of multi-sectoral groups coming together to rethink the way that zero-dose children with multiple deprivations are having their needs met, and where the gaps are, and really thinking beyond perhaps traditional or current approaches, and really promoting innovation and creative thinking around how to move forward. So moving on from these steps, just to provide a little more detail, phase 1 of the program cycle outlines pre-planning steps for that initial conceptualization. There are tools to help assess feasibility, mobilizing key stakeholders, and developing a shared vision of collaboration and integration. Phase 2 is around design of an integrated approach and provides steps in setting up and review of a multi-sectoral coordination framework. We'll hear a little more about an example of this later in our webinar, and so that you can hear how this actually takes place. Stage 2 is identification of zero-dose and under-vaccinated children and missed communities, and stage 3, contextualization for priority settings. So here we have really focused on some of the priority settings at this point, in terms of urban settings, and including informal settlements, support for middle-income countries that often have less support to to guide them through multi-sectoral processes, and then humanitarian, fragile, and conflict-affected settings. Fozia, just so you're aware, your camera is on. I'm not sure if you can hear me. And then in stage 4, integrated program design, around mobilizing the program planning team, engaging with government and community stakeholders, jointly developing the program design, and we have multiple tools and annexes which provide references for particularly these stages of the process. And then you can see here action plans, how to carry out multi-sectoral analysis and integrated program design. In phase 3 of program cycle, this summarizes the approach to collaborative action during implementation. So it really just provides some considerations for maintaining effective multi-sectoral linkages throughout implementation, and strengthening the advocacy throughout all stages of programming. And then phase 4 guides development of an integrated monitoring and accountability framework. And this is jointly developed. And then, as you saw in the initial diagram, follows an iterative and and adaptive process. The implementation tools that come along with this are a zero-dose multisectoral theory of change, which can be adapted to each context, and then an integrated logical framework to measure the effectiveness of coordination, and provision of a number of suggested indicators that can be reviewed and considered for the monitoring framework. Our key cross-cutting themes that we've brought out in the guidance are gender mainstreaming, this is really key not to lose focus on as working together as multiple sectors. And we've brought in climate action in terms of strengthening the sustainability of health systems, including immunization systems, and increasing resilience of those systems to climate events and other emergencies. The structure of the guidance is includes tips throughout for very practical application. And then we also include case studies with representation from various regions around the world, and annexes with various resources that are relevant at each stage of the program cycle. We also have, at the time that we published this guidance 2 months ago, we've also published a case study compendium, which highlights multisectoral linkages to address the needs of zero-dose children. So it includes 4 in-depth case studies. As part of the guidance, we include a lot of case studies bringing out the multisectoral mechanisms and approaches and how these have worked. And within the case study compendium, we've dived a little deeper and really tried to bring out the mechanisms and the systems that have been used and the way that multisectoral stakeholders have worked together across various settings. This QR code links to the actual resource, and we will be providing these on the TechNext site following the webinar today so that you can also access them then. So here I would like to take us into our first panel discussion, and we are highlighting today the case study from the Philippines, reaching every Purok in urban poor communities through linkages with education, social policy, and the private sector. Joining me today to have a discussion will be Dr. Carla Anteorosco, who works for UNICEF's Philippines country office, and she has an extensive experience in maternal and child health and has been managing and supporting immunization programs for some time, including various multisectoral initiatives in the Philippines. And Dr. Edvir Jane Montagne works for the Republic of Philippines Department of Health, and she has a number of leadership roles there, including regional program manager for the National Immunization Program for Soxcargan region. And we're going to hear from her today about the Regional Immunization Coalition, which is the first multisectoral immunization coalition in the Philippines. So I'm looking forward to speaking to both of them about multisectoral initiatives. We'd like to start by just sharing with you a recording of the Philippines case study so that you can hear about that work before we speak to Carla.
Good day, everyone. I'm Dr. Madonna Anyabieza from the Philippines.
We've lost the volume testing.
Desiree, I think we lost the sound.
Yeah. Desiree, you are muted if you are speaking.
Apologies, you lost the sound.
Yes.
Okay. Let me try again.
Good day, everyone. I'm Dr. Madonna Anyabieza
Good.
from the Philippines, and I'm honored to share with
Yes.
you a case study on strengthening multi-sectoral linkages to reach zero-dose children, focusing on our integrated programming efforts through the Reaching Every Porok strategy. But before we dive into the program details, here's a brief overview of the Philippines. The Philippines is an archipelago in the Southeast Asia, comprising of over 7,000 islands. The Philippines is classified as a lower middle income country by the World Bank, characterized by persistent inequities in health and social services, especially in urban poor areas. The country operates under a devolved government system where local government units, or LGUs, have significant autonomy in the implementation of health and social programs. The country is divided into regions, province, cities or municipalities, and barangays as the smallest administrative division. And according to the 2094 United Nations estimates, the Philippines has a population of approximately 118 million people, with a large proportion living in dense urban environments. Urban areas, especially Metro Manila, host large informal settlements with underserved populations. This context significantly shapes how health interventions like immunization are delivered. Now, the Reaching Every Porok strategy, or REP strategy, was introduced in 2016 as a direct response to fragmented immunization efforts and low LGU ownership. It aims to reduce health inequities and sought to improve immunization access by enhancing primary healthcare delivery, particularly in the pilot 44 densely populated urban poor communities in Manila and Taguig City. The identified barriers then to uptake included poor awareness of services due to very mobile and transient population in highly urbanized areas, while it's also secondary to prevalence of opportunistic work. It also included high transfer costs, lack of knowledge due to poor health literacy, as well as gender-related barriers. While health system barriers included poor knowledge of planning and budgeting at LGUs, low ratio of healthcare workers to population, as well as limited clinic hours offered for vaccination, were what we all focused to address through the REP strategy. The REP strategy brought together a wide range of stakeholders, and what made this approach distinct was its multi-sectoral collaboration, bringing together the Department of Health, city health offices, local government units, Department of Social Welfare and Development, Department of Interior and Local Government, police and military forces, religious groups, civic organizations, and more. Engagement of both public and private healthcare facilities created a comprehensive support network. This collective ownership was crucial to driving change. Key strategies included micro-planning at community and barangay levels, capacity building workshop for healthcare workers, as well as local leaders, and strong community engagement. We also aligned vaccination efforts with the education enrollment by reinforcing vaccination requirements through school enrollment policies and nutrition programs, as well as leveraging the cash transfer programs to increase adherence of beneficiaries to routine and catch-up vaccination sessions, thereby maximizing touchpoints with families. Results from the 2016 to 2018 efforts led to the 20% increase in MCV2 and 20% increase in the fully immunized children, or FIC, in Taguig City and 18% in Manila City, respectively, Dropout rates as well decreased from 41 to 13% in Manila and from 42 to 5% in Taguig. But more importantly, to be able to sustain these early gains from 2016 to 2018, governance and accountability of local leaders were strengthened. From understanding and addressing their context-specific barriers, improved community engagement, as well as tracking or monitoring of results. And despite the setbacks from the measles and polio outbreaks, as well as COVID-19 pandemic, we managed the DTP1 coverage to decrease from 78% to 57% during the first 2 years of the COVID-19 pandemic. And recovery to 78% was achieved by 2023 in reference to WINIC. And thus, which proved the value of a coordinated, localized approach in high-need areas despite overwhelming supply and demand-side issues, concerns, and barriers. The project, however, also faced multiple challenges, from the vaccine hesitancy due to the dengue vaccine controversy, security threats in informal settlements, resource strain caused by competing priorities, as well as strain on the health system due to the large measles and polio outbreaks from 2019 to the COVID-19 pandemic in 2020, which led to the premature end of the pilot after just 2 years. Moreover, data privacy concerns in the private health sector, and additionally, the decentralized health governance structure required high coordination effort with limited resources. But despite this, community engagement remains strong. Thus, if we aim to decrease inequities in health service delivery, including in immunization, particularly the zero-dose children in highly urbanized areas, we learned that it is important to localize the REP strategy by involving all the leaders and influencers from situational analysis and planning to mapping and doing stakeholder engagement, and also leveraging existing community structures to lead to greater program ownership and sustainability. And therefore, by making use of multi-sectoral collaboration, we were able to enhance the scope of our impact beyond traditional health systems. Political commitment, strong leadership, governance and accountability, and multi-sectoral involvement were the key enablers in the REP strategy. Involving budget offices, education, social welfare, and local government leaders early on helped solidify the program's foundation and enhance accountability, while coordinated linkages across national to community levels ensured sustainability. The REP strategy offers a promising model and illustrates how localized, multi-sectoral coordination can help bridge immunization gaps for zero-dose children, even in complex urban settings. Thank you for listening and for your time. I look forward to your questions or clarifications.
Okay, thank you all for listening. That's from our colleague Madonna Anabiesa and UNICEF Philippines. I'd now like to invite Carla and Jane to join me, just as we have a panel discussion. Hope you're both. Hi, Carla.
Hi, good morning, good afternoon, good evening, everyone.
And I think Jane is there with us also. Carla, as we start, I'd just like to reflect back on the presentation that we've just seen and this work that was carried out beginning in 2016, and a very successful program, although it was ended after 2 years due to various factors. But could you tell us about how the Philippines UNICEF office has supported multi-sectoral initiatives, and how this urban REP program led to other multi-sectoral work in the Philippines?
Yeah, Thank you for this opportunity, Desiree and Ibrahim as well and colleagues. So the REP experience, the reaching every Porok, or it's reaching every community that has been shown in the video. It started at the city level with support from UNICEF and in close collaboration with the Department of Health and of course the local government unit. So after that pilot implementation, we did assessment, and the results of the assessment we also shared with the Department of Health. And the experience that we had, we also helped to support other local government units as well where we work after that initial implementation in the two cities in Manila. And beyond the local government level, we actually envisioned a multi-sectoral coalition now at the national level. So that's the offshoot. It started at the city level, then we looked at the national level, and we envisioned that there can also be a national level coalition of different stakeholders that will be led by an organized stakeholders association or coalition. So we call it coalition building. So that's the start of this vision, and that's one of the offshoot of our experience in that city, in those two cities. So the start of this vision came into being with conduct. We also supported this, the first National Immunization Summit. The summit also brings together different stakeholders, from different organizations, so national government agencies, the academe, the professional medical societies, association of midwives, association of deans of and colleges of nursing and midwifery as well as medicine. So they came together, and the goal is to really to create that coalition. So this was done in 2023 and also in 2024. There were separate meetings as well to develop the commitments from these different sectors. And after that, the different subnational level, we also tried to support. So Philippines has from national, subnational is regions. So regions also, the regional level led by the Department of Health there also had their different regional immunization summit with that in mind as well, to develop a coalition of different stakeholders. Many regions conducted the summit, but what really came into advanced implementation is the one led by Dr. Jane Montañer, who's here from Region 12. So the Philippines has 17 regions. So the Region 12 Soc-Surgeon Regional Immunization Coalition, and other regions were also starting off, like Region 5 and Region 4B. So it's actually now a movement of different stakeholders for immunization that started actually from that pilot implementation of the Reaching Every Community strategy in the two cities in Metro Manila. So that's where we are at as a result of that initial urban Reaching Every Porok strategy implementation.
Thanks, Carla.
Over to you. That's right.
Thank you. I'd like to bring Jane in now just for her to tell us a little about the coalition. And Jane, I know that under your coordination, you have brought together more than 15 national government agencies. You brought into the coalition civil society organizations, academic institutes, and faith-based and health societies, forming formal partnerships. So I'd like to ask you to just tell us a little more about the Regional Immunization Coalition and yeah, thank you. Apologies. And where sectors and stakeholders are involved. Thank you.
Good morning, good afternoon, and good evening, everyone. So first and foremost, I would like to express my sincere gratitude for this invitation. It is an honor for me to be part of this event and to share our experience of the Software Generation Immunization Coalition, or the ISIC, which is the first multi-sectoral coalition on immunization in the Philippines. So ISRIC, as we call it, was created in response to persistent immunization gaps and recurring vaccine-preventable diseases outbreaks in regions. Recognizing that no single agency could address these complex challenges alone. So DOH cannot solve the problem on vaccine challenges. So we built ISRIC as a unified platform to bring together diverse sectors, align our efforts, and co-develop innovative, sustainable strategies to improve the immunization coverage of winter. So, like what we have said, Ma'am Desiree, ISRIC is a multisectoral membership that includes the national government agencies. More than 15 of those were included, like, of course, the Department of Health, the Department of Education, Department of Social Welfare Development. Of course, we need to have um, our key pillars in the local government. So we have with us the Department of Interior and Local Government, the academy. We also have the Commission on Higher Education, the TESLA for the technical skills of our health workers, as well as for the repair of the refrigeration and the other national government. Of course, we also have members from the local government units who are our frontliners who that provides immunization services. We also have civil society organizations, including local advocacy groups and professional associations. So for our CSO, we have the FTOP, or the Family Planning Organization of the Philippines, and our private midwives association. For development partners, of course, with the help of UNICEF. So they are our main support, our big support for this district. And our professional societies from our pediatric and medical associations, lending technical expertise as well as influence. We also have members from the academic institutions who are have a vital um, um, role in the workforce development. And this, our nursing, as well as our midwifery students and our medicine students, could assist our local healthcare workers in the service delivering as well as demand generation activities. Also, members of ISRIC are our private sectors, our local media and local businesses who could support and is supporting us with our advocacies, logistics, and as well as mobilization. And lastly, our faith-based and community groups like our IT leaders, our religious groups who helps us foster trust and demand at the grassroots level. So to ensure structured and accountable collaboration, district is organized into a steering committee, which is the strategic oversight, the technical working group, which is the one in charge for the evidence-based guidance and monitoring. Also, we have the sub-working group for governance, service delivery, and demand generation, as well as a wide base of general members, all united under a signed memorandum of understanding. So we have already have a ceremonial signing of the MOU during our second Soxford Immunization Summit last April 8th. So that is how we have established ISRIC, which is the first coalition, immunization coalition in the field.
Thank you, Jane. It's a really impressive list of achievements and stakeholders that you've brought together under the coalition. And I would just like to ask, can you share about one challenge that you've faced in that process of, working together with multisectoral, this many multisectoral stakeholders, and how you overcame that challenge?
Thank you for that. Actually, we have a lot of challenges, but one of our major challenges is during the creation of district was the coordinating diverse stakeholders because not all of them are into health. So each of these agencies, our partners, have their own priorities, they have their own mandates, as well as levels of engagement. So early on, aligning expectations and building a shared vision across all these sectors required focus and ongoing effort. Some of the agencies were initially unclear about their roles, immunization because they are not on health. They are not part of the Department of Health or our healthcare workforce. So they have different mandates. So when others are faced on resource and institutional constraints, and also we have encountered logistical challenges also arose in coordinating activities across different governance levels and systems. And another is we have problems securing sustained political support and funding was an ongoing concern. And we are so glad and very thankful to UNICEF for assisting us, not only for technical assistance, but also the support in funding most of our activities in building this coalition.
Thank you, Jane. Carla, I'd just like to come back to you because I think in the Philippines case study and in the example of the coalition, we see very ambitious goals in terms of bringing together these stakeholders and often, for example, in the urban setting, non-traditional stakeholders that perhaps haven't been worked with previously. And I'd just like to ask you, how do you think that multisectoral collaboration improves outcomes for children, and what challenges maybe does it bring along with it?
Maybe our principle, we work on the premise that health should not be the sole responsibility of the health sector and not by the Department of Health alone. So the multi-sectoral collaboration, it rallies different stakeholders. It creates awareness on the immunization situation, maybe beginning with immunization, but it can go beyond immunization even, because as mentioned earlier, those children also faces other multiple deprivations. So it starts from there, the awareness, and then it also creates commitment from these different stakeholders once they learn of their possible role or contribution based on their mandates as well. Can be the academe, it can be youth organizations because we tap them also in the work on immunization. So it gives them sort of a role to play and contribute to that improvement, to that goal to improve immunization outcomes. So because of these commitments, there is the sharing of resources, which contributes to better implementation of the immunization program. And even beyond that, it really can improve immunization outcomes. So basically, the collaboration, the coalition of different stakeholders, it's like a movement that goes beyond health. And in the Philippines, because there's a robust list of different stakeholders from the private sector, from the government agencies, as mentioned. So it's just opportune that we tap into them, we tap into their commitments, into their resources as well, and contribute to better immunization outcomes. It's a shared responsibility, actually. In terms of challenges, I can't think of many. Well, I think the challenges, as mentioned by Jane, is more on the getting first the commitment and buy-in of these different stakeholders. And I think we also experience at the national level, who leads the coalition. Initially, it will be the Department of Health, but how we envision it to be in the future is that maybe it's not even the Department of Health, but actually the coalition itself that can be led by someone from the private sector or from the academe. They can really organize themselves, and they can even meet on their own accord. They will be the official officers as well that are that can really plan on how to support immunization. the national level and at the subnational level as well.
Great.
Yeah, so I think that's it. Thank you.
Thank you so much, Carla, and thank you, Jane, as well, for joining us. I'm now going to hand back over to Ibrahim, who will take us into the next panel discussion.
Thank you, Desiree. Thank you, colleagues, for this great panel discussion. So we quickly go into the next one. Basically, this is going to describe the experience from the rollout in the first country, Libya. And we have, as part of the panelists, Dr. Salim, who is currently the National EPI Manager. We have Dr. Fauzia, who is the Head of Family Medicine and Primary Healthcare. We have Dr. Taufik, who heads the International Cooperation Office and the Social Solidarity Fund. And our colleague, Ala, Dr. Ala, who is a health specialist based in our regional office in Amman. So, colleagues, Dr. Salim, we're going to start with you. I know in the last few weeks, you worked on developing the first, the Libyan National Multisectoral Plan to reach zero dose from this guidance, leveraging on this guidance. Could you please briefly describe your experience on how those could help address the needs of zero dose and under-vaccinated children? Welcome, Dr. Salim, and over to you, please.
Thank you, Dr. Ibrahim. Thank you, my dear colleagues. First of all, I would like to introduce that as a Libyan country, we are proud to be the first country to apply the operational guidance and the experience that have been both valuable and transformative through the multisectorial workshop that we have held in last month, in collaboration with the country office UNICEF at Libya. We did this multisectorial workshop, including the primary healthcare institute, which are the responsible for delivering other healthcare services, and the Ministry of Education with the Ministry of Social Welfare. And we have drafted our new committee, multisectorial committee, to reach out those children with zero dose status. Also, we agreed that we have different rules to map out those children with zero dose status, as the primary healthcare institute help us to identify the health system gaps and service delivery, and also the educational sector will provide us for the school enrollment and to help us out to map out that school children who have been missing their vaccination. And also for the social welfare, offered also community level information, especially for those who are vulnerable and underserved population. So along with all those sectors, we are decided to include other sectors like Ministry of Local Governance to help us to reach out those children at the vulnerable communities, and also to serve the underserved community, especially the migrants and those who are a bit far from the basic healthcare services.
Thank you, Dr. Salim. And just to quickly, do you want to talk briefly in terms of the vulnerabilities you see for zero-dose children, what kind of deprivations you've seen in Libya, particularly for children that are identified as they've missed their vaccination?
To be honest, we found that those who are missing their vaccinations, also missing another opportunities for the healthcare services and for other services like nutrition. And to map out those children, it's a bit struggling, because we, as the vaccination services, apart from the health services at the country level, we could not identify those who are not reaching out the vaccination status. But along with the social welfare and the education ministries, they helped us also to break the ice on the children who has health services, especially the vaccination status. Just to mention that Libya had reached 91% of coverage from the DBT1 for the last year. And for the previous years, we have struggled with the stock out vaccines, especially for the last 4 years, sorry, the 2 years of COVID-19 and the later 2 years of COVID-19. And that what makes the families did not reach the some of the healthcare facilities to get their vaccination. And due to this stock out, we had developed the zero dose children along with the migrants who came with the zero dose status, unfortunately.
Thank you, Dr. Salim. And it's great to hear that we're targeting every child because that's our overall mission to make sure that no one is left behind. So I move to Dr. Fauzia, who heads the family medicine and primary healthcare. Dr. Fauzia, considering that this is an approach to strengthen PhD, some may say this is like a PhD plus. How do you think the formal collaboration formed through this workshop will help support primary healthcare priorities? Dr. Fauzia, over to you.
Yes, thank you. Thank you for your question, Dr. Ibrahim. I will answer in Arabic if it's okay.
Yes, that's fine. Yes, we have translators.
So, Primary Healthcare Plus is this is our target now when we start this project with the ABI, our national ABI, and we think of this BHC Plus. And لأني رئيس قسم طب الأسرة في مؤسسة الرعاية الصحية الأولية في وزارة الصحة الليبية، أرى أن التعاون
multisectorial cooperation after this workshop with the UNICEF, supervised by the UNICEF, this cooperation or step was the first step actually that was important to foster healthcare, which we can call the enhanced primary care or primary care, healthcare plus. We had 3 points. 3 points are very important that will be supported through this program. Accessing zero-dose children by working with the Ministry of Education, as social care, NGOs, and this enhances the comprehensiveness of healthcare that we can provide to zero-dose children because they have other health services. This is going to be a chance to provide to them all the services needed. Secondly, enhancing trust in order to stop this hesitancy of vaccine immunization, because actually people, not other people were sure or confident of the immunization. After COVID-19 is different from the before COVID-19, because there were rumors that some people said that the vaccination was actually harmful. That's why many people did not take the vaccine. Those zero-dose children appeared because of the stockout of vaccines. So we had the zero-dose campaign started. So confidence and community collaboration help us in overcoming challenges of hesitancy. This is very crucial for primary care. Third and last point is sustainability and strengthening of the health system by adopting a flexible program that takes into account climate changes and some crises of the zero-dose children that made them lag behind. These 3 points were had priority of the Ministry of Health in order to strongly approach this. I hope I answered this question. This plan gave us a chance to rebuild the primary health plan and to have equality and access to regions in order to reach the vulnerable national or immigrant children, because Libya has many migrants who are not linked to healthcare services.
Thank you so much, Dr. Fauzia. And I think this is great to hear about how this is going to help consolidate systems, strengthening and identifying zero dose. So let's go to Dr. Taufik. Dr. Taufik heads the International Cooperation Office. and social welfare. And a lot of the points Dr. Taufik has been referring to migrants, people with children with disability, and different perspectives in terms of zero dose. How do you think this workshop or the operational guidance, the workshop you had, has helped to advance and bring that agenda more to the limelight? Over to you, Dr. Taufik. Yes, so I said, based on the comments that have been made by your colleagues, what can you say briefly in terms of the needs of households and children accessing services, including vaccination, from your perspective? Over.
Thank you very much, Dr. Ibrahim. Good morning, good afternoon, good evening for everyone. Just I want to summarize the challenges that can challenges for those children to reach the zero dose. I want to summarize these challenges in the 4 points. First of all, if we want to talk about the data, lack of the data, because many children with a disability are not formally registered, and the disability data is not routinely shared between the health and the social sector. This is the first point. The second challenge what we are facing is the geographical and physical barrier. A family may live in the remote and underserviced area, and many health facilities are not physically accessible. The third point is the social stigma. Parents may be hesitant to seek the service due to fear of discrimination or lack of awareness. And the final point is the fragmentation of the service. As we know, health and the social service often operate in the silos, leading to the gap in the follow-up and the outreach. So as we discussed in the workshop, to enhance the cooperation between the social welfare and DBI, we suggest the 4 points to overcome these challenges. The first one is the data sharing and integration. How we can establish the link between the social welfare beneficiary registry with the health outreach system to identify unvaccinated children with this disability. This is the first one. The second one is joint outreach campaign, which coordinate mobile and home-based visit through the social worker and the health team. The third point is capacity building, so we can train both the social worker and ABI team on inclusive approach and disability sensitive communication. And the final one is the referral protocol. We should establish a clear referral and feedback mechanism between the social welfare and the health clinic. This from my side. Over to you, Dr. Ibrahim. Thank you.
Thank you, Dr. Taufik. Thank you so much. So next we move to Ala, our colleague. Ala, based on the perspectives shared by our Libya country colleagues, what were your key impressions? You were there in the workshop. So what were your key impressions on how the multisectoral collaboration can support zero dose agenda, particularly in the countries and regions as well as globally? Please, Ala, comment.
Thank you, Dr. Ibrahim, and thank you, colleagues. I really want to take this opportunity to thank all the colleagues and partners in Libya under the leadership of Dr. Salim and the Ministry of Health, and all the support from UNICEF country office. And from your side, Ibrahim, from HQ side, of course, it's been crucial to make this successful. I think the multi-sectoral approach in MENA region is a very promising a platform that we can go for and go even beyond Libya and to extend that support for further countries. In MENA, we have children suffering from multiple deprivations, especially in the last few years, not only from COVID, but from mostly the conflict-related issues. What is also special in MENA region is that all the countries have strong potentials. They have strong foundations already. Maybe they are suffering from existing issues, but there are a lot of capacities to mobilize more resources and to make this multi-sectoral approach win-win situation and make make it successful. So I think what I can tell about my impression probably in the workshop is that this approach will not only support the zero-dose children and to minimize or reduce it, but also it will support the whole EBI program and to support the completion of the vaccination schedule for all children. But beyond that, it's supporting the whole health systems and even more outcomes that that the children can benefit from. I think it's crucial to make it win-win situation between the different sectors coming together. They all have different objectives. They have different desires. So it's better. I think the key is how to make it successful and how to make everyone wanted to contribute in that platform. So it won't be only for immunization. Of course, immunization may be in the lead. Health system is the platform. But I think to make it successful, we want to make all sectors desire to come and to participate in this. So I think that will be the critical one. I think one observation that mapping of stakeholders and the multi-sectoral partners should continue. You cannot identify the set of partners that you will collaborate with. You should continue with that mapping. Even when you go to in the implementation process, you should always look for further partners who can come and engage and support this approach. Thank you, Dr. Brahim.
Yeah, thank you, Ala. These are great points and great reflections. Thank you so much. And great to hear that we have Nadia Albakush, who is the Director of Department of Social Services, the School Health and Psychological Support from the Ministry of Education. Nadia, welcome. And great that you are joining us. Please, during the workshop, some of the key immunization priorities were identified that all sectors felt strongly committed to supporting going forward, including joint awareness raising to address the rise of vaccine hesitancy. In what ways do you think the formal collaboration will enhance the coordination of activities between EPI and education? Nadia, can you come in, please? Nadia, are you online? Okay, maybe she has technical glitch. So, Dr. Salim, I see your hand. I know you wanted to come in to say something. Please come in, Dr. Salim.
Thank you so much. I would like to tell you that Dr. Nadia is on us online, but I think she had some struggling on the internet connection.
Okay, that's no worries. Thank you. Okay, so basically, so I think we need to hear from you any final sentences in terms of what will you say to countries and programs that are planning to roll out this operational guidance in one sentence? Dr. Salim, we start with you.
Could you repeat it again, please, Dr. Brahim?
Okay, one sentence. What advice will you give to countries when they are rolling out this operational guidance? Over to you.
It's very, very useful, and we're gonna use this opportunity to develop our plans in the multi-sectors. I mean that it will be much beneficial for the vaccination department at the NCDC, and also we can use this plan for every sector to integrate other services in collaboration with the other sectors throughout this multisectorial committee or group or stakeholders. And I really recommend to use this multi-sectorial approach to reach out zero-dose children, and it will be much beneficial for the other services that you are providing in different sectors. Thank you. And I would like also to thank UNICEF. I know also I would like to thank UNICEF on all levels, on the Minaro level, on the Libyan country office level, on the HQ level, to choose Libya to start off such an incredible experience for the multi-dose zero-dose children, multi-sectorial zero-dose children. Thank you so much.
Thank you, Dr. Salim, and great to hear from you. And for making time for this. Dr. Fauzia and Taufik, any final words, please come in. Dr. Fauzia.
نعم أهلا دكتور إبراهيم
نعم.
أعتذر أني صارت تقطعات شوية.
Sorry, I had some connectivity issues. In fact, this multisectorial approach is actually excellent, and the workshop led by the UNICEF in Libya was really very useful, and hopefully we shall have further cooperation between different sectors. The representatives of such sectors are optimists that there will be practical cooperation, especially in the gap areas and zero those children. There will be common and shared resources to guarantee sustainability of basic health services given to those children who are the axis of working with this program, because they have multi needs. And all these we shall discuss them in the primary sector, in the multisectorial cooperation. We wish success for Libya and for all the countries that will follow suit. Thank you all.
Thank you, Dr. Fauzia. Dr. Taufik, please come in. Naam.
Thank you, UNICEF, on all levels for helping us implement this program. I'm very proud that this program will be applied in Libya for the first time. We, in the social affairs sector, we shall give full support for the success of this program. And I would like to thank you all again. God's peace and mercy be upon you, and thank you all.
Wa alaikum assalam. Thank you so much. Thank you, colleagues. And at this point, we end this panel session. Thank you all, the Libya team, for making time despite your tight schedule. Thank you so much. So we move to the next slide, please, Desiree. So we're going to question and answers. I know we have some questions that were typed in the Q&A box, and some we've responded through the chat. Desiree, are there any specific questions you want to come in? And colleagues, please feel free to scan this and provide an evaluation to the session while we do the question and answer. Desiree, please come in.
Sure. Yeah, we would like to invite people to ask questions live if they have any to any of the panelists or regarding the guidance itself. I will just answer a question from Laura Shemp. Thank you, Laura. She has said, thanks for this learning. How has this guidance been adapted in severely resource-constrained areas where microplanning resources are always insufficient and humanitarian groups are closest to communities, but the nexus with resilience to consistently reach missed children takes long-term efforts and support? I hope that the panel, presentations with Libya has, at least in part, helped to answer that question for you. I think the rollout workshop was conducted with Libya stakeholders just a few weeks ago, and which obviously, has been a country affected by conflict and has constrained resources in some areas. I think, if any of the panelists would like to come in and answer this as well, please feel free to make a comment. I think from my perspective, we found that actually the rollout of the guidance really was effective in the way that it was designed to be, in terms of bringing people from across sectors into the same room, and over the course of a few days really discussing together what are the barriers, and it really was, I think, quite a remarkable process in terms of alignment that took place over a few days, and then a really great consensus around what initiatives could be taken going forward. And just to highlight that out of that workshop, there's a proposal to form a formal committee recognized at government level to take forward these plans as a multi-sectoral initiative, and we really hope, that with an actual kind of costed draft plan, which will be taken forward. So yeah, I hope that answers your question. I think in terms of contextualization, it's really about bringing the right stakeholders into the room and allowing them to identify, facilitating them to identify the way forward.
Thank you, Desiree. Yeah, thank you. And I see Paban, do you want to come in? I see your hands up, please. Paban, come in. Unmute and speak. Paban. Okay, we move to Godfrey. Please, Godfrey, unmute and speak.
Yeah, thank you so much, Ibrahim and Desiree, for a very powerful product. I think the timing was perfect, especially now that we are seeing decreased funding for this type of work that we do. So it's important that we're able to do more with less. And also, it's also important for the countries to have stronger ownership so that we don't see the gaps that as a result of COVID. We want to see them reduce, but the resources for us to be able to do that are not necessarily available. So once again, thank you so much.
Yeah, thank you. Thank you so much, Godfrey. And I think this is quite helpful. There were questions with respect to, if I recall, Mira made some questions with respect to monitoring indicators. And I said we had some such sections within the document that talks about joint M&E, basically providing principles and guidance, and also some suggestions in terms of what joint indicators are going to look like. So it will be interesting to hear. And yeah, please, if you want to come in, let me know.
There is a question from Raja Al-Ghadi.
Okay, please.
Says, thank you to our colleagues from Libya for this interesting discussion. I would like to know what the obstacles were to integrating multi-sectorality. Was it challenging to invite other sectors outside the health sector to participate? And what about advocacy efforts? Dr. Salam, I don't know if you want to answer this question.
Dr. Salam,
To be honest, yes. To be honest, thank you for the great question. We had already some channels with the other sectors, but it was really very narrow, strict on specific projects regarding the vaccination. I mean, like with the education, we have the routine school health vaccination, and we did not had that strong relationship that we had just after this collaborative approach throughout this workshop. And as well as we have shared responsibilities with Primary Healthcare Institute along with the National Center of Disease Control regarding providing the vaccination as a part of integrated services. But I think this workshop had allowed us to know that this multi-sectoral approach, including other sectors at the same time on the same target population, I mean the zero-dose children, is really effective. And as I can illustrate it, it was very sporadic collaboration, but I think this integrated one, when we have all together on the same table, on the same target, I think it's very comprehensive and multi-sectorial approach is much more powerful than the single or bilateral collaboration on other health issues.
Thank you, Dr. Salim, and kudos to you guys for able to bring the different sectors, education, social policy, PhD to the discussion. I think it was wonderful. Tato, you want to come in? Please unmute. Tato Mokhele. Just, can you unmute?
Dr. Ibrahim.
Yes, please.
Yeah, I just would like to add something. I'm Dr. Sam Shneshah, the Libyan EPI manager.
Yes, please.
To be honest, this workshop also addressed the political gaps and the political instability and political fragmentation between the sectors and between the sides of Libya, the eastern and the western, because I think most of you know that we have some political issues regarding the governance on the highest level, and this workshop had gathered the people from different sectors, from different regions, to reach out the those children with the zero dose status, and without this approach, I think it would be much difficult to have those people on the same table for this target. Thank you.
Thank you, Dr. Salim. Thank you so much for this additional comment. Desiree, I see the question from Well Done, Rido. You want to respond to this?
Yeah, sure. Well Done, Reid has asked, has said, thanks for sharing. I'm Well Done from Indonesia. Sorry, I think for delivering the robust and tailored strategy with multi-sectoral stakeholders, it should be conducted as a quick survey, for example, rapid community assessment by health workers and local sectors as a key step to defining the role and collaboration strategy. I'm wondering if there's any guidance, particularly mapping out the decision trees, or if we face several similar types of obstacles in cross-sectoral work. Yeah, within the guidance, we do actually highlight various ways in which data gaps can be met. And I think we're actually in the process right now of planning for more rollout workshops, and we're actually incorporating a rapid community assessment approach along with the multisectoral approach, and we're combining the two. So it's a really great point that you make. I think within the guidance, we do try to identify as many sort of options and suggestions and practical suggestions on what to use where there are gaps in data and so on, or at various stages of the program cycle. So thanks for your comments and question.
Okay, thank you. Thank you so much. And yeah, some of the questions we are not able to answer. So we'll be able to respond and maybe share as part of the total package. The recordings of the sessions will be shared with all of you, I think, as well as the materials that were presented. Thank you so much for your participation and collaboration. Thanks particularly to TechNet, Alex, and crew for making this possible, and to our different partners, the WHO, Gavi, CDC, and other partners that have been part of this operational guidance development and also the webinar itself. Thank you so much. So I think we give you back 5 minutes, and we wrap up at this point. Thank you, and God bless. Over. Thank you.
And please, we'd appreciate you evaluating the webinar using the QR link. Thank you.
Thank you.